Welcome everybody to the March version of Rochester Lifestyle Medicine Institute's Lifestyle Medicine Grand Rounds, co-hosted with William J. Folletti Center for Lifestyle Medicine in Ann Arbor, Michigan. We'd love to partner with all the medical professionals out there in the audience. We can help you empower your patients. We have a number of Zoom-based facilitated programs which build motivation and competence in a socially supportive, interactive environment. And two of our three programs are ACLM certified. The third program is our health coaching, and that is not ACLM certified, but we'd love to have you join us for that as well. Online referral forms are available on our website. If you're a busy clinician, you can just have one of your staff fill it out, and we will contact your patient on your behalf. These are the three main programs that we do run, in addition to Lifestyle Medicine Grand Rounds, of course. And you'll see that you can receive 10 CMEs if you are a healthcare professional, if you go through our 15-day whole food plant-based jumpstart, or if you go through our Lift project. Either of those will get you 10 CMEs. And there is very little charge for that. You just have to pay for the program, but not for the CMEs. And please respect the privacy of any patient's information. Of course, we do everything we can to keep things hidden away unless the patients have expressly given permission to be presented. Our case presenter tonight is Dr. Saul Bautista, who serves as Director of Medical Education and Community Engagement at Ethos Farm to Health, a nonprofit integrating healthcare with regenerative farming. He's a graduate of Rutgers, and he introduced lifestyle medicine within medical education in New Jersey with the foundation of the Rutgers Lifestyle Medicine Group. At Ethos Farm to Health, Dr. Bautista is piloting a lifestyle medicine program with Rutgers and serves on the board for Newark's Department of Health and Community Wellness. Dr. Bautista's future pursuits lie in preventive and lifestyle medicine with a vision to foster communities that cultivate a culture of health to prevent chronic disease by empowering individuals to manage their well-being. Dr. Rebecca Monk is our guest panelist tonight. She is a University of Rochester professor of medicine. She has been chief of medicine at Highland Hospital, a major teaching hospital in Rochester, since 2022. She has served the health system for almost 30 years, most recently as chief of the nephrology division at Highland Hospital and medical director of the Highland Hospital Inpatient Dialysis Unit. She served as program director of the URMC Nephrology Fellowship for 12 years and started the CRRT program at URMC in 1994. She is medical director of the Irondequoit Bay Dialysis Unit in Webster, New York, and she also serves as an advisory board to Rochester Lifestyle Medicine Institute. Dr. Robert Brakey is one of our regular panelists, along with Dr. Melissa Sunderman. I'm not going to read their biographies. You can just stop this video and read it on your own. And case coordinator is Dr. Carrie Graff, who also serves as our medical director. And again, you can read that if you happen to be watching the video. And I am Dr. Ted Barnett, president and founder of Rochester Lifestyle Medicine Institute. Sometimes I'm known as Dr. Veggie. Thank you for attending tonight. We are a nonprofit, and we welcome your donations. You can either aim your phone at that QR code, or you can go to the chat and see where the link is in the chat, or you can go to Rochester Lifestyle Medicine Institute.org and see how to make a donation there. And again, we appreciate your support. And now, without further ado, I'd like to turn it over to Dr. Saul Bautista, who will be talking about lifestyle medicine for cardiovascular kidney metabolic syndrome. Welcome, Dr. Bautista. So Dr. Bautista, take it away, please.
All right, so thank you everyone for your attention. Today we will be discussing community lifestyle medicine and its utilization for patients with cardiovascular kidney and metabolic syndrome. So brief overview, we'll review the origins of a community-based approach to care, the development and design of community lifestyle medicine programs, participant case studies, some insights, and a conclusion. A few disclaimers. So the presented cases have provided written and verbal consent to share their images and results as part of this case presentation. The data and consent is in conjunction with the Rutgers IRB, and listed here is the approval number. And also you can also find our study registered with clinicaltrials.gov, and here is the clinical trial number. When I was a resident, I would frequently care for patients and try to communicate lifestyle medicine principles in one-on-one visits. And what I found was that although patients were internalizing the information in the and they were excited to apply these principles, they ran into difficulty when they went back home, when they went back into where they lived, into their communities. And so it really got me thinking that perhaps the best way to approach lifestyle medicine is where people work, live, and play. And interestingly enough, I found an article when I was a resident from the Society of Teachers of Family Medicine that talked about this very concept of a community-based and community-owned approach, that clinicians, we should partner with community agencies, and whether it be restaurants, farmers markets, schools, food pantries, the health department, city hall, cafes, local fitness groups, and work collaboratively to care for people. Um, this idea that people come and get their care at an academic medical center or a clinic, and that is the only place where healthcare is applied. Uh, I, Perhaps at this time is a little outdated, and it's time for us to evolve a little bit in order to effectively deliver care. And the idea is that we as clinicians, to deliver the best care, we should map our communities and understand them in order to improve care and advocacy. And we should form enduring partnerships to really align care with the community's priorities. And this idea, it's not a new idea. It's not a novel idea. It actually is as old as the profession itself. So Rudolf Virchow, who's best known for Virchow's triad, actually is also known as the father of social medicine as well. And one of his postulates, we'll look at postulate 3, talks that the actions to promote health and to combat disease and the measures involved in those actions have to be social as well as medical. So this idea that we deliver healthcare merely within the walls of the clinic, in the hospital, with technical interventions, it's only half of the equation. That these social and behavioral interventions, say getting patients access to food, fresh produce through a food box distribution program, or getting them access to say a living space. If they don't have a living space, that's also part of the health continuum, and it's important. And so lifestyle medicine delivery is delivered a number of ways. What we're starting to see predominantly is the delivery of lifestyle medicine programs in clinical spaces, either through a one-on-one visit or working with a multidisciplinary team. We've also seen lifestyle medicine delivered through group sessions or shared medical appointments, such as the CHIP program or the Ornish program. And we've also seen lifestyle medicine delivered through community programs, such as Dr. Barnett's Jumpstart program or the Healthy Neighborhood Immersion Strategy by the Kellen Foundation and Dr. Megan Grega in Pennsylvania. And using that strategy, they target food access, culinary education in the Kellen kitchens, lifestyle medicine, and they also engage students in schools to impact the entire neighborhood infrastructure. And so, in returning to my hometown of New Jersey, uh, we knew and understood that we couldn't just impact the patients individually, one-on-one in a clinical visit. That to really transform their health, we needed to transform the place where they lived. And so we wanted to operate within 3 pillars of education, food systems, and healthcare. That if we can get these 3 domains to work collaboratively, uh, we can actually drive forward lifestyle medicine and delivery of lifestyle medicine. So, in looking at education, wouldn't it be wonderful if we had more clinicians that were trained in lifestyle medicine and adopted this as an approach to care? If every federally qualified health center and every major healthcare institution in the area had a lifestyle medicine program with clinicians that practice lifestyle medicine. And so we knew that in order to do that, we needed to have a high school, college, and professional pipeline that emphasized this as an approach to care. in order to have lifestyle medicine oriented professionals. Wouldn't it be wonderful to have what we call a health promoting food economy? So the infrastructure already exists in that people source food, they distribute food, and people prepare and consume food. What if that food was simply prepared in a health promoting way that's evidence based, aligned with methods that we know improve health or reverse disease? And wouldn't it be wonderful if we had existing programs? And so we wanted to design a lifestyle medicine pilot or trial because there was no lifestyle medicine program in our area or health system that was doing it. And we want to create this program to work in conjunction with existing food-based organizations like local markets, local food aggregators, and also work with medical students or high school students and show them that this is an approach to care and other health professionals. Again, having a clinician to form these enduring partnerships and creating this integrated web to deliver care. And that's what we did. So we partnered with a local academic center. We partnered with Rutgers and actually three institutions within Rutgers: the Rutgers School of Public Health, the Rutgers New Jersey Medical School, and the Rutgers School of Health Related Professions, specifically their physical therapy department, and their Department of Dietetics, as well as the Urban Agriculture Cooperative, which was a food-based nonprofit that serves as a local aggregator, sourcing produce from local farms, curating them into local food boxes that they distribute to schools, to local health clinics, and for us, they would curate boxes for our lifestyle medicine program. And the Greater Newark Conservancy, which is an environmentally oriented nutrition organization that has a teaching kitchen in their institution where they would do culinary education and urban agriculture education with the local community. And we also engaged our local represented leaders because in order to drive collective change and implement policy, we needed to engage our lawmakers as stakeholders as well. And kudos to Senator Booker's team. It was their advocacy and their support that really helped to bring that gravitas to what we were trying to do and that validity that this was important, and that brought all these individuals together. And so we were fortunate to be able to pilot a lifestyle medicine program after 2 years of hard work. We piloted a program. Uh, our project design, we wanted to take 3 cohorts of 20 people. The first cohort, we would deliver a lifestyle medicine program where they would get culinary education, exercise education, some activities in urban agriculture, as well as 12 weeks worth of fresh produce boxes, all for free. The second cohort would simply receive food boxes and be given 12 weeks worth of fresh produce boxes without any sort of education. And the third cohort would receive the standard of care. And for our lifestyle medicine group, they would receive 3 hours worth of contact time once a week. And again, this is just a quick overview. They would get 5 culinary sessions with a chef and doctor learning how to prepare health promoting meals, 5 exercise sessions with our physical therapists, free fresh produce boxes provided by the Urban Agriculture Cooperative, and they would get a wearable in the form of a Garmin watch and physical and clinical assessments to assess their fitness and other metrics. Really quickly, we wanted to use an evidence-based health behavior change model to guide the design of our intervention. And so we wanted to use the trans-theoretical model of change as we felt that it would guide participants through all aspects of change, from preparation and contemplation to action. And there were different and there were different modalities to how we would help move patients through each domain. So we would use lifestyle medicine education to move them through that sort of contemplation phase, in-class conversation, and also goal setting to help them move through those initial stages. And then some of the experiential activities like exercise classes and the social connectedness in the group to help them sustain the behaviors. We would measure in all participants the following metrics. We wanted to measure clinical and social metrics. So the clinical metrics were blood pressure, uh, waist circumference, waist to hip ratio, BMI, which are common body anthropometric measures. And we also wanted to measure markers of fitness, such as VO2 max, which is a commonly known metric for cardiovascular fitness, and grip strength and total body strength. Our primary endpoint was medication reduction, deprescription, or the improvement of the initial risk factor that qualified them for the program. And we also wanted to look at those social metrics. As Virchow stated, the actions should be not only medical, but social as well. So we wanted to look at food security. We wanted to look at dietary quality, cooking and produce use self-efficacy, and self-reported physical activity. In terms of recruitment, we recruited patients that had cardiovascular kidney metabolic syndrome as described by the American Heart Association as our primary inclusion criteria. And as far as our exclusion criteria, we did not want to take patients who were uncontrolled, that had any sort of uncontrolled or acute cardiac, pulmonary, neuropsychological, renal conditions. They could not be on a GLP-1. They could not have history of bariatric surgery or pregnancy, just because that population has special needs. And we also didn't want participants to have acute unresolved health-related social needs. So as we know from Maslow's hierarchy of needs, if you don't have transportation or housing and you're very stressed about that, it's very unlikely that you'll want to engage in an intervention that's tied to your health. That becomes the least of your priorities when these social needs are more pressing. In terms of our recruitment, we initially wanted to recruit from the local family medicine clinic. However, we pivoted to recruiting within the community, and we attended farmers markets, community festivals. We went to different nonprofit organization events, and we found that we were more successful in recruiting from the community itself than in the clinic. And just a quick anecdote and insight. For some reason, participants within a clinical space, there seemed to be the sentiment of distrust. And so further engaging with the health system for a program being offered was not appealing to patients. However, in a commercial or community setting, patients were very open to participating in a clinical program. It didn't seem as threatening because it was done in collaboration with community organizations. So let's define cardiovascular kidney metabolic syndrome. So cardiovascular kidney metabolic syndrome essentially is a progression of risk factors that are really integrated. So most patients that we encounter, they don't just have one risk factor. If we have a patient that's afflicted with obesity, they'll usually have hypertension or high cholesterol, or they'll have diabetes. And subsequently, if these things are exacerbated and worsen, they'll progress to chronic kidney disease, they'll progress to heart failure, cardiovascular disease, and ultimately other aspects of cardiovascular disease to include peripheral arterial disease, arrhythmias, cardiovascular stroke. And what the American Heart Association wanted to describe with this was that that these constellation of symptoms don't happen in isolation. They're part of an integrated progression, and that we should identify participants at specific stages and target different interventions to look at all these risk factors in unison and target all of them. And the reason we chose this classification really was to be pragmatic. was that when we're conducting a trial, it's very difficult to compare a diabetic patient or a hypertensive patient. Usually they say, hey, if you're going to conduct this intervention, all your patients should be diabetics or all your patients should be hypertensive. What this classification allows us to do is to take participants with different risk factors and categorize them by one stage in unison. So we're able to compare them and also integrate them all. So for our intervention, we had a total of 13 participants in the first cohort of the lifestyle medicine cohort. 5 of them were in stage 1, 6 of them were in stage 2. We did not have any participants in stage 3, and we only had 2 participants that had stage 4 with known cardiovascular diseases. So starting with our participant case, this was a 35-year-old female that was afflicted with obesity, class 3 obesity. She did not have any reported past medical history, was not on any medication. Family history was notable for having type 2 diabetes and obesity in her mother. And her father had type 2 diabetes, cardiovascular risk factors. She wasn't very specific, but she did mention that her father passed away in his early 60s from a myocardial infarction. In terms of her lifestyle history, she did not see herself as being athletic when she was growing up. And actually, her first foray into physical activity was in 2021, where she started with CrossFit. And again, she was very apprehensive. And then she eventually progressed into powerlifting. So she felt empowered in seeing how her body can move and that, hey, oh, I can pick up heavy things and get better at this. But she still continued to have a lack of confidence into moving her body to do other things like Pilates, yoga, dance, climbing, hiking, running. And she didn't have any confidence. In terms of nutrition, she disclosed to me, she would tell me that she used to start dinner with dessert because and the reason she always started dinner with dessert was because she did not want to eat her meals, get to the end of her meal and be so full that she couldn't have dessert. So, and she also reported that she didn't eat vegetables, that leafy greens, any sort of vegetable, tomatoes were not part of her diet. She did not enjoy the taste. The most she had was like rice, corn tortillas, and then it would always be some form of like meat, dairy, cheese. She did sleep well, and she did have a strong social support network. She regularly attended church, would socialize with her friends, spent a lot of times with friends and family. And in terms of her stress management, she attended therapy regularly. And a lot of her sessions in therapy really were tied to her body image and obesity. So quick poll. So the participant has apprehension about initiating cardiovascular activity. How would you help this person to start? And would you refer them to a personal trainer or a health coach? It's a very common technique that we use in lifestyle medicine. Tell them to, hey, just start walking. Very common advice that's sort of low entry for people. It has a low barrier to entry is just having patients walk. You could develop a fitness plan and have them meet you at a specific location and time. There are clinicians that do that. One example is walk with a doc. Or D, give them resources for beginner running plans that they can choose from online and just say, hey, here's this plan. Here's a couple of websites you can go to.
Okay, let's see what the results are. Okay, let's see. I'm going to ask our panelists where they would have started. I'm going to start with Dr. Sunderman.
Well, since I am in this program with Dr. Bautista and totally involved in the community, and I like to exercise, ideally, when I'm going through these, I'm always thinking about, developing SMART goals or fit. And when I look at B, start them to just walking a few times per week. That's not ticking those boxes of being specific and measurable and attainable and, and having a SMART goal. It's just too loose. Again, D, she's already apprehensive about, moving her body in a different way than powerlifting, that if I just point her to an online thing, I think that that's just going to be something that she's not going to be able to follow through with. Refer them to a personal trainer or coach. That, I mean, depending upon if I have a good affiliation with that personal trainer, but again, that feels like just a handoff. So in an ideal world, I would love to be able to do C. And I think that Dr. Batista talked about Walk with the Doc, which is a wonderful program. And then we also have medical fitness centers. So I think that would be amazing if clinicians could actually participate in a group fitness program, help them develop, and do this together, and just sort of again talking about this integrative approach.
Oh.
So I'm going to pick C.
Okay, awesome. Dr. Monk, what would you pick? I know what I would pick.
I like the idea of I'm as a busy physician, nephrologist, I don't know how I would be. I think for a lot of physicians seeing patients, I'm just wondering how they make time to do that. Although I do think that having some kind of community to engage the patient in exercise would be great. We have someone who does sort of a walk with the doc for us at Highland. And I think that's worked really, really well for people. They get to know each other. They're talking with each other. They're getting outside in all weather, and that's been fabulous. So I think having community in some way to involve her would be great. I'm curious to see how you find the time to meet every patient for exercise, though, if that is the answer.
Right. Dr. Brakey.
I wanted E, all of the above. There's really kind of benefit to each or any of these. In my current practice, where I have lifestyle medicine only, I do have the benefit of an exercise physiologist on our team. So that's kind of why I picked A. I refer to our exercise physiologist, RJ, and he'd be able to develop a custom approach, which is kind of like C. And he meets with them if needed. He does phone. Otherwise, but I realize most people don't have the benefit of that kind of team approach. And I see why, therefore, a lot of people just picked B because, hey, just getting someone walking is great start. And it doesn't take, extra team members, too much additional motivation or teaching. Everybody knows how to walk, and just getting them started doing something, because the data shows that doing a little is where you get the maximum effect, and then incrementally less with each additional amount, and eventually it plateaus at about 300 minutes a week. Well, we don't know. There's some benefit beyond that, but the best benefit is just getting started. So I can see how people could pick any of these, and my personal was A, just because of my setting.
Thanks for that. I'm going to actually make a comment myself. As someone who's really interested in how to operationalize lifestyle medicine, I really think A is the best. We really need to be promoting the whole idea of having health coaches available to our patients, because, as Dr. Monk said, it's not really practical for most people to do C unless you only have a few patients. So, I'm going to turn this back over to Dr. Bautista. Continue, please.
So the truth is, all the answers are actually correct, because it's dependent upon one, what are your resources that are available to you in the community you serve. So if you're part of a direct primary care practice, and let's say you don't have a health coach available to you, or patients can't afford it, then that may not be the right approach. Right? Some patients are more motivated than others. Some patients say, "Hey, doc, just tell me to walk," and they'll do it. Some patients need a little bit of a guided experience, so that may not be the right one for them. In our case, we chose to develop a very specific fitness plan and have them meet with us. They met with me, and that was for two reasons: one, to create accountability, and second, It was for me to be able to show them in real time the right intensity and how to do these things in a way that are not intimidating. Most participants, when they start to say run, most people go and run too hard and they're out of breath very quickly and it is miserable. The approach that we take is showing people that they can just run a quarter mile or an eighth of a mile at a conversational pace. And taking that approach, they feel very accomplished. The next component, in choosing a plan, what principles of exercise programming would you prioritize in this participant?
I think that one's going to take longer for people to fill out if you're anything like me. So I didn't really know what those were.
All right, everyone. So I did get a little bit technical. So this comes from the National Society of Strength and Conditioning Coaches Association. And so these are just some basic principles of exercise programming. I think at ACLM, they use the FIT principle that comes from the American College of Sports Medicine, which is frequency, intensity, time, and type. This talks about different components that are important in when we're designing a plan for a patient. So for this person, we thought that individualization, which is meaning creating something that is specific to their needs and their challenges, was going to be very important. Having a plan with the right amount of what we call overload, meaning the right stimulus, right volume. So for this person, we chose saying, hey, they're going to run a quarter mile 3 times a week to start, and then at the right progression. So say week 1, you started at a quarter mile, do that 3 times per week. The following week, you'll do half a mile. And then the week after that, 3/4 of a mile. That was very powerful for this participant because it gave her confidence. Again, this is something she had never thought she could do. And when she finished running her first quarter mile, she's like, oh my God, I did it. Then the following week, she did it. And she continued. And what she noticed was week after week was that she was getting better. And within 4 months, she went from not running at all to, as you can see, running 10 miles.
Wow.
And she would come and weight train, and having that social support, having someone that can guide her, made all the difference. And again, this is just a picture of her engaging with a local run club. So again, the handoff with the clinician, our vision and our idea was that, hey, we will coach her in the beginning, give her the tools, and once she develops the confidence, let's connect her to an existing community asset, which is the existing run club, because now they're already doing programs, but now she has the confidence skills to engage with this organization and participate in their programming, and it's not intimidating. So now we did a handoff, and she goes to that run club frequently, will join and meet up with other people in that organization, and she'll just do it independently. And again, and went from doing nothing to that in 4 months. So what happens? So what happens when we do this? So within a matter of 12 weeks, and to be fair, the patient went from, again, 240 pounds. Her final weight by the end of the program, she was 198. I started engaging with her a little bit prior to program start because she had asked me, and that's kind of how we got her into the program. So she was technically 228, but she lost a total of 30 pounds. So looking at different metrics, her BMI decreased from 40 to 35, so dropped an entire class. Her waist circumference, again, dropped about 7 inches. Her waist to hip ratio dropped from being at risk down to normal for women. So normal for women is below 0.8. And her total body strength had improved dramatically, going from 0.98 to almost a 25% increase. And her VO2 max, more importantly, from the time she started running, she started at a level of 26, which places her at really high risk for cardiovascular disease. She got it basically almost to being in the average or normal range for her age group at 34. And I want to go over, I'll skip this for now, but I just want to go over a few perspectives worth exploring and why we looked at those metrics.
Dr. Bautista, sorry to interrupt. I noticed that her resting heart rate actually was increased. It was 80 and then it went up to 86.
Yep.
Do you think that was just like a one-off? I mean, in general, if she was getting more physically fit, her, more athletic, her resting heart rate, I would think would decrease. So do you think that's just kind of like when you took the blood pressure, she was maybe a little nervous, or, like, what do you think that's related to, if anything?
Yeah, that's a great observation. And that was one I noted. So when participants go get their physical assessment done, they sort of walk into the PT clinic, and it's really our PT staff that has the participants undergo the assessments. And I think what may have just happened was she walked up the stairs, walked through the door, walked down the hallway, walked in, stood in, did her height and weight, and then did her blood pressure and resting heart rate. And perhaps the students who was there probably did not have her rest for about a period of 5 minutes.
Yeah.
So again, yeah.
Yeah. And since you're using the Garmin's, and that's probably where you're pulling your VO2 max from, I think, is that because I'm an avid Garmin wearer, it does have that resting heart rate on your Garmin. So maybe like going forward, just to maybe avoid that issue, is take the resting heart rate from the Garmin wearable rather than what them walking down the hallway and then taking the vitals right away. Just a thought.
You're 100% right, and I was debating that. I think part of the challenge that we ran into was that some of the participants where we had attrition, some people did not wear their wearables. So when we were trying to compare the group in its totality, we had to go by, if not everybody wore their wearables. But that's a great point. And to your point, her resting heart rate was in the 60s actually when we looked at her Garmin. Just a couple perspectives to look at. I think for lifestyle medicine, it's very important that we look at objective measures of well-being. So it's like, I think people looked at, oh, I'm healthy, looking at it from the absence of disease. But when we're looking for optimal health, how do we know that someone, they're at their best in terms of their cardiovascular fitness, in terms of their muscle strength? People can say that they're strong, but how do we measure that? Just how we would measure any other lab to assess risk. And so this was a great publication by the American Heart Association, looking at cardiorespiratory fitness and its measurement in clinical practice, looking at fitness as a vital sign. And so what we know is that cardiorespiratory fitness, it's as good of a predictor for mortality as established risk factors like cigarette smoking, hypertension, cholesterol, and type 2 diabetes. And that when patients increase their cardiorespiratory fitness, it actually decreases their cardiovascular disease risk. And that's measured and assessed via VO2 max. And so she went from being in the lowest category, as you can see in these blocks here, we'll look at the blocks for women. She went down from having low fitness to moderate. So she experienced almost a 4-fold drop in her mortality risk. And again, she went from having a VO2 max of 26 to about 34. That's about an 8-point increase. And so every 3.5, every increase in your VO2 max of 3.5 causes close to a 15% drop. So she had roughly a 37% drop in her cardiovascular disease and mortality risk. So that's why I like that metric. And we can objectively show the patient, hey, when you're running and you're not only decreasing your times, that's increasing your VO2 max, which is decreasing your risk for cardiovascular disease. It makes the connection for patients. How does my behavior relate to my health? How does doing this thing that is not fun relate to my health goal? And it makes it very tangible and concrete for patients. And I think it works well for adherence. The last thing I wanted to leave you with was, we often think about how exercise improves glucose control and insulin sensitivity, but how exactly does exercise do that? And when I was a medical student, a first-year medical student, I stumbled upon this article that talked about skeletal muscle as a secretory organ. And there's this idea that every time we exercise, skeletal muscle will release proteins that then create signaling cascades in other organs. And when we look at diabetes specifically, muscle-derived release of IL-6 will then drive release of GLP-1 in intestinal cells. Now, for me, that's very powerful, because when I talk to patients, it's about connecting their behaviors to their health goals. And so when patients, it's like, oh, why do I have to exercise and how does that improve my diabetes? Hey, you can think of it, I kind of use this framing and say, hey, you can think of it like giving yourself your own mini Ozempic dose. It's not the same, let's be very clear. Ozempic or Wegovy, those are sort of like copies of the GLP-1 that you make in your body. It's slightly different, and the dose is way, way higher, and it's given at a different frequency. But every time you exercise, you can think of it as if giving yourself your own Ozempic dose. You exercise, drive release of that IL-6, which then interacts with L cells in the intestine to drive release of GLP-1. And what I have found is that, again, that just helps with adherence. And it makes it, again, very concrete for patients. How does my behavior impact my physiology that's related to a disease process? And this makes a lot of sense for me, because when we look at recommendations for pharmacotherapy, let's say metformin, we're giving metformin at a certain frequency, twice a day, at a certain intensity or dose, say 500 milligrams, for a certain amount of time, and it's delivered a certain type of way, either orally or IV. Metformin obviously is delivered orally. Well, exercise is delivered that same way. With that, the FIT principle matters in that exercise has to be prescribed at a certain frequency, say 2 to 3 times a week, at a certain intensity, say exercises, say at 75% over one rep maximum, or 8 to 12 repetitions, where that last repetition is close to failure. I believe that the intensity, that these parameters matter, and using myokine cell signaling, it makes sense, because say when we exercise, we secrete these myokines that then interact with the receptor. That effect, that downstream effect, is not constitutively active. It only lasts for a certain duration. So say I exercised on Monday, and I'll drive a process. I'll drive that GLP-1 release. So I'll drive the increase in lipolysis or vasodilation. But that process will not continue. It will only last for a certain period of time, right? And it will extinguish unless I exercise again, drive some more myokine release, bind the receptor, and trigger that downstream process all over again. And it kind of makes sense, because if, say, you don't take your antihypertensive today, you take it today and you don't take it again the rest of the week, you won't have that physiological impact of driving down your blood pressure. Or if I take the medication and I take it Monday, Tuesday, Wednesday, Thursday, but I don't take it at the right dose, same thing. It's not going to lead to a positive effect. The point I want to drive home is that the frequency, intensity of exercise matters to drive a physiological benefit. And I think for us as clinicians, we need to, when we're prescribing lifestyle medicine, it's important for us to have this perspective to better understand how we can combat disease processes with lifestyle medicine.
This was great. Thank you so much, Dr. Bautista. Dr. Monk, any final thoughts?
First, I just want to ask you, Dr. Bautista, the point you were making at the end, are you saying that we have to be prescriptive, more like we prescribe our medications, that we have to tell everyone they have to do this every day consistently in order to derive the benefits? Is that what you're trying to get? Because like if they're going to take if they're not going to take metformin, they're going to have to get that they're going to have to get their GLP-1. They can't miss too many days, or they can't have a day off. Is that? I'm just trying to. I'm not sure what you were saying at the end there.
I think that it's important for us to be as specific and as prescriptive as possible, because I think that's where a lot of frustration lies for patients. They'll go, we've had patients that say, hey, I've been biking for a whole year. Why is my blood pressure not going down? And I'll look at the patient's sort of training history, and I can see that the intensity isn't high enough. And so, and then when I look at it from that physiological lens, I'm like, oh, this makes sense, right? If I'm looking at it, if we're looking at it in order to induce a positive health benefit.
Yeah.
So that's just a small example of where that can be helpful.
That makes a lot of sense. I mean, I'm the simple nephrologist in the group. So I will just say that I found this very impressive. I think your study was great. What you brought to you brought us all of this exercise physiology, and I learned a new term. I actually have been looking at a lot of literature, and I have not seen CKM used in anything that I've read, this cardiovascular kidney metabolic syndrome, although it is something that we see a lot. I mean, we're all, anyone who's taking care of anyone who has diabetes, hypertension, kidney disease, heart disease, they all go together, and we're all seeing all of those together. Your patient, was frankly hypertensive when you first saw her. She had a blood pressure of 140 over 100. And I don't know if it was true hypertension or if it was just one elevated reading, but she was overweight, she was hypertensive, she was at high risk for not just heart disease, but developing kidney disease, having protein in her urine, progressing to having other cardiovascular complications. And, within 4 months, you had her no longer hypertensive, exercising, and her weight is better, her waist to hip, all of those things are just so much better. And her prognosis is so much better, not just even from the exercise physiology standpoint of the VO2 max, which I think is impressive. And I'm going to have to get myself one of those little Garmin's now. As Melissa said, mine doesn't, doesn't give you VO2 max. So it's just really impressive. And I also want to say, we did a study of a whole food plant-based diet using the Jumpstart. We invited people to do that. And we took patients with CKD 3 and 4. And we also found it hard to recruit patients, even from our clinics, even with patients who have a little more trust in the system. Getting patients to buy into all of this is not easy. But kudos to you. I think this is just a fabulous program, and it's very impressive.
Great. Thank you, Dr.
Thank you,
Monk.
Dr. Monk.
Yeah, Dr. Sunderman, your thoughts, please.
Okay, well, you are preaching to the choir when you talk that she started running and that she started off at just a quarter of a mile, and I'm always saying 1% better. And what I've found in being an avid runner myself is the group is huge, right? So I belong to group running clubs, and I also pace. I pace anywhere from a 5K to a marathon. I'm flying to Milan, Italy next week to pace the marathon and to see what people once they can wrap their mind around that, you can try this, and it starts with just one baby step, right? And it's 10,000 baby steps that can add up. So that is just wonderful. I think that's great that you're incorporating the community and the group, and that's wonderful. And then also, I love the whole myokine, and Kelly McGonigal from Stanford, who wrote a book all about myokines and calls them the hope molecule, because really it is this hope molecule with the myokines and elevating our mood. And I've been doing some speaking engagements. I've been partnering with Dr. Gia Merlot, who's lifestyle psychiatry out of NYU. And she speaks about lifestyle psychiatry in terms of movement, and then we incorporate nature. And what I found really impressive is that when she looks at interventions for mood, and I know we're talking about here about, cardiovascular, metabolic, kidney disease, but even in looking at mood and exercise, when we talk about number to treat, and number to treat is how many people do you need out of group on a certain intervention to get one to improve? With SSRIs for depression, the number to treat is 7. For exercise, the number to treat is 2, meaning that for every 2 people, one person is going to get better for exercise intervention for mood, versus when you're looking at an SSRI or standard of care, it takes 7 patients for one person to get better. And then third is that last Tuesday, I got to speak for Ted's group about brain health and dementia. And, studies showing, when we're talking about the epidemic of dementia, the UK Biobank study, 80,000 participants, if people could get at least 3,800 steps per day, they could decrease the risk of dementia by up to 25%. If they up that to 9,800 steps per day, they could decrease the risk of dementia by 50%. So again, exercise prescriptions, we all need to be prescribing this. Like Dr. Monk was saying, like, do we write these prescriptions? Absolutely. We write exercise prescriptions and treat it just as seriously, because they can be just as powerful as our pharmaceuticals. And then I put the ploy for write your nature prescription as well, 20 minutes a day.
Yes.
Love it. Great. Thank you. Yeah.
Fantastic.
Dr. Brakey.
Yes, thank you at the end for this concept of the subtherapeutic dose. Just like if you did a study on Tylenol and pain control, you started with a 0.5 milligram and you made it 10-fold up to 5 milligrams, and then 100-fold up to 50 milligrams, you would conclude that Tylenol doesn't help for pain control, where you haven't given enough. And the same thing we often do with either diet, exercise, or stress management prescriptions. And this is one of the kind of keys to helping people, is to give them enough of a prescription to make it work. Also, assessing that, of course, your emphasis on exercise is critical, and all the pillars are synergistic. As I put in the comments, endurance athletes actually have a higher risk of cardiovascular disease if they're on the standard American diet. And the reason for that is that they eat more calories of saturated fat, cholesterol, ultra-processed foods, sugar, oil, salt. And with that comes artery clogging in spite of exercise. So we really need to kind of focus, as you did in your program, on all of the pillars. And then lastly, it's great to know that exercise is a GLP-1 agonist. So is dietary fiber, whether it comes from beans, whole grains, fruits, or vegetables. It's only about 1/8 the effective or the kind of strength or potency as the Ozempic. So we can't say that it totally kind of replaces that in all cases. But it also has, of course, the benefit of forming short-chain fatty acids, which induce satiety. So for people looking for weight loss, combination of exercise and high fiber, that is, i.e. whole food, plant-based diet, can help them in so many ways to decrease the risk of these multiple chronic diseases, including obesity, which is the root of many of them. So thank you for your presentation, for your great work. And I just love these concepts of involving the community, because it does take a village, a team, to help get through the challenging aspects of getting people to change behavior.
Getting back to that, if I could just ask, how much change have you been able to affect in Newark? Are there more options for people to go to restaurants that are plant-based? You were really working, it sounds like you had a lot of buy-in. You met with Cory Booker, I don't know, or was that what it was? Was there support for providing more, that which would be fabulous. It's hard. Even in Rochester, we struggle in everywhere.
Yeah, great. Thank you. Go ahead, Saul.
So there's a lot of dynamics at play. Right now, there's this discussion of trying to build a community food hub that's sponsored by the existing large healthcare system. They're basically going to sign a 10-year lease in a very beautiful downtown location to build a food hub where our community partner that's creating these boxes and aggregating produce, food hub where we not only have aggregation and distribution, but a teaching kitchen. And so I'm part of those conversations. Again, they're very delicate in that because it involves a nonprofit organization which is a community partner. The major health system, again, I think for health systems, there's a lot of unanswered questions about risk in terms of economic investment, liability, and in terms of governance as well, because they have to rely on community partners to deliver the programming. There's a lot of conversations that had to be had, and people to sort of come together in agreement. They are well on their way. I think they plan to try to launch in fall of 2025. But again, there's a lot of unanswered questions in terms of program delivery, who's going to do what. And as you know, it takes time to get everyone to agree and to say, hey, we agree on this, doing this in this specific way. But the fact that the health system is actually engaging and sort of getting them up to speed on lifestyle medicine and these sort of care models, it just takes time and engagement, but they're coming around.
Mm-hmm. You know, it's really, really fascinating.
Yeah, and
Amazing.
having spent time with Megan Grega and what she and Eric Ruth have built with Kellen Foundation, you know,
Mhm.
similar to what you're doing. And they really have formed some great alliances with the community and with St. Luke's, which is their health system there. And, you know, every time I go back to visit, you know, Kellen Foundation and what Megan's been able to build, and they've been doing it for a while now, I think, gosh, well over a decade. So they started small, but they've, you know, been at it and not giving up, and they're in the school system. So I think they're in like something like 18 or 20 different schools doing interventions in the schools, and then they have their kitchen and they're doing the medically tailored meals. And yeah, so kudos to what you're doing out there and what Megan's doing out there, because it's much needed.
Yes,
Thank
great
you.
work. Hey, Dr. Bautista, I wonder, you presented a couple of the cases from the intervention group. Did you also do a median and average results for blood pressure, weight loss, the other metrics that you looked at for intervention versus control group? How was the aggregate results?
So that's actually what we're working on currently. So we just concluded the first group, which ran from November to mid-January. So, and we're currently in the middle of our second cohort right now. The School of Public Health, they just started to analyze the data, compile it and analyze it from the first cohort. I was able to show you a little bit of the raw figures that I kind of just pulled from the files, but they're doing that right now, actually. I hope that within a month they'll be finished. But when I do,
Okay, we'll look forward to seeing the results. It's very exciting work. Thank you.
Do you get together with all of your patients and run with them? Or do you, I mean, how do you, or just the ones in the study, or, you know, how do you work? Do you have a life outside of this?
Yeah. So I think that this is where it's interesting, and I don't think there's any right one model, but I did want to. For me, I just wanted to do this as an experiment. Like, hey, I would spend 8 hours a day in clinic seeing patients one by one, and I was like, man, I could do this more effectively in 3 hours, take all 16 patients in 3 hours, communicate the same information that I would deliver in each visit, and also engage with them in physical activity. I could probably do it all at once in a shorter time block. And so this was just an experiment of this idea I had in residency. And I was like, I just wanted to see if it would be more effective. Like, could my time as a clinician, can I get RVUs for this, right? Like, because if I'm helping them to reverse these metrics in 3 hours once a week, well, more than 3 hours once a week, because I'm meeting with them outside, but say 10 hours of my time a week, I think that's better than 8 hours per day. It's more effective. So again, this is just an exploration and trying to demonstrate this with data so that maybe in the future we can ask for these things in terms of reimbursement.
Yeah.
But I think somebody has to do it.
Yeah, that's great. Okay, any other comments or questions from the audience while we're out here in the lobby? And our panelists, you are free to go. Thank you so much for coming, but I know it's getting late. And Dr. Graff, thank you. Dr. Monk, again, thank you. Dr. Brakey. Everybody is free to leave at this point, but we will stick around for a little bit longer. Is there anybody in the audience who wanted to bring up a question?
As a family physician, and I practiced community health for over 20 years, and it's just reminding me of group visits, what Dr. Bautista is speaking about as far as walking with patients. And it was always a struggle to get those reimbursed, but sometimes they were. So I'm just wondering, this is so wonderful to hear and see, and especially coming from a specialist and what you were getting into about exercise as a prescription. But I do wonder, and why not? We really should be able to get reimbursed for this. Is there some way to help lobby for that, or what can we do to really encourage that to happen? Because I mean, I'm watching this and listening, and I think there even is data from the community health field that shows, we really do make an impact. I mean, I remember seeing people just with diabetes improve when we had group visits implemented where they talked to each other. One of us would see 10 people in a room and they would share what worked for them. So, I mean, it's very exciting, but I'm almost surprised that we're still talking about it and still not getting reimbursed for it.
Mhm.
Yeah, Dr. Brakey, I was going to call on
Yeah.
you. You're the expert on SMAs.
Yeah, we've been doing SMAs now for 3 years in person and for 1.5 years virtual, and we get reimbursed. You do have to follow the same protocol you'd use for a medical visit and cover their actual individual medical concerns as part of that visit, record their needs, your teaching, what you've done for them. I'd say 95% of them are 99214s. Or with a modifier for virtual if we do it virtual. I've got a cohort of 15 coming tomorrow afternoon, virtual, and we do general lifestyle medicine group visits with a focus on CAD, hypertension, obesity, and diabetes. We sometimes will expand to autoimmune disease or CKD, but we try to kind of keep, and obviously people with the same category of metabolic syndrome have a similar root cause for these, mostly the standard American diet, but they do help and support each other. They have great patient satisfaction. We've calculated that if we get 6.5 or more in the group, it's worth our time as far as, or improved our time over just seeing, 2 or 3 an hour in the clinic. But we follow the ACLM model, well outlined by their group visit protocols, and it's going very well.
What did you call it, Bob? SMAs? What is that?
So shared medical appointment.
Shared medical appointment. Got it. Okay.
Yeah. Yeah, just another name for group visits. Yeah.
Okay.
Dr. Brakey, as long as you're on the subject, can you just explain the concept? Because it sounds like it may be new for some people, but the idea that you can bill everybody for the same code,
Yeah.
right, in the room. So go ahead.
Yeah, we of course, my pre-charting, these are patients from our group, so I can see their problems at first. And for my group tomorrow, I've already got outlined these are doctor that referred them, their age, their health conditions, so I can say, okay, We start with about a 10-minute overview. Here's lifestyle medicine. Here's how it applies to the common conditions we see. And then we go around one at a time, just as if you're talking with your doctor in a medical visit. Hey, I would really like to get off my medicine, but my doctor doesn't want me to. My cholesterol went up when I started eating this way. What's happening? And we answer that, and people answer for each other or help each other. Yeah, I was in that place when I first started, and here's what happened to me, and here's what helped, and share some recipes. They develop that group support kind of system to it. And as you go around to each one, giving them about their 5 minutes each, you have a wrap up. You set some goals. Usually, if it's virtual, I have them put them in the chat. And it's a simple one session goal. I will walk 15 minutes 3 times a week. I will eat vegetables twice a day. I will, fill in the blank. They're working on whatever pillar is most pertinent to them. We put those in the notes. We send a note to their primary care doc, just like as if it were a consult visit. We invite them to come back, and some people are repeaters for group visits because they find that group session works very well, and they get something different out of each one because it's always a different visit each time. But yeah, it's a real medical visit. And again, our coders have looked at it. You do have to meet the criteria just like you would. You can't use time because they're all there for 2 hours. But you have to meet the criteria for, hey, I addressed these at least 2 chronic conditions, some custom approach to that, what their cholesterol was, what you recommend they get back with their doctor to request either testing or other. And as I say, most of them, because of their conditions, end up with a 1-4. Sometimes we get a relatively healthy person just trying to prevent disease, which qualifies as a 1-3. But it can work very well. The Cleveland Clinic does a lot of group visits around just regular medical care. But we find lifestyle medicine is very helpful.
I'm sorry, and you're writing a note for every one of those 15 patients?
Everyone, yep. That's why it's not just 2 hours worth. If you had afterwards, it takes me about 5 minutes for each one. So tomorrow after my visit, I'll be working another hour and a half. But again, I could never see 15 people in 3.5 hours.
Yeah.
So it still makes more than what they do. We also have it's kind of like the airlines, deliberate overbooking. We don't expect more than 12 of those to show up because there's no, they've made a reservation, but they haven't paid anything if they do. And 12 really is about the max that's easy to kind of get through in 2 hours because you want to give everybody a chance to ask their questions. But you have to write a note if you're going to bill for it.
Mhm.
Otherwise, it's just a didactic seminar session, and you can charge them if you want, but their insurance isn't going to pay it.
Yeah, interesting.
Mhm.
That's great. Thank you.
Yeah, a lot of people think this is really the future of lifestyle medicine. I mean, that's ACLM has been saying that for a long time now, that this is really the only way it's going to really work because you just need to spend a lot of time with people. Dr.
It's
Breaky,
very
can you?
amenable to that. Yeah.
Yeah, no, it's actually quite brilliant. And actually, and the note take, if you're really efficient at making your note and you have a template, it's 5 minutes maximum, right? So
Yeah, we have a standard template for everything things we cover in each visit. We customize it for here's a few additional things. I have a colleague, either our health coach Nan or our exercise physiologist RJ, with me on the group visit. They take notes and pass them to me by email after the visit. I paste those into the person's after visit summary and into their note for their doctor so they see what we covered, what we recommended. It works very well.
yeah. Do you think you could do that with a group walk?
Yeah, I do that too with my particular group, just like Saul mentioned, is meet them for a walk in the woods, and it's very well received. People love that.
Nice. I love that. That's
We
great.
can't charge for it though.
You can't charge for the walk?
No, we haven't found a way to do that, but
We got to figure that part out. Dr. Bautista, what are your thoughts?
That's exactly what I wanted to ask about was just for my reference, because in consulting for this food hub and sort of like lifestyle center that's potentially being built, we were talking about mechanisms for billing, and we looked at the SMA model. And what I couldn't find guidance on, and maybe you can help me, was could you bill for a group visit multiple times a week? So if the person came in on Monday, Wednesday, Friday, or is it just hey, you came in Monday, but we'll see you for another group visit next month or 3 weeks from now. What is the frequency of billing if they're coming in, again, for culinary classes, or if they're coming in for exercise classes? Or is that
I
something
think
that we have to advocate for?
insurance tends to get testy if you're saying they need a medical visit every 2 days. You know, how sick are they? So I think in that case, you do you kind of like I don't know, Ted, if this was part of Jumpstart or so, I don't know. No, I guess you weren't doing something, but what some are doing in that case is charging for one of those as a group visit, and the others are more either didactic or follow up or assistance or coaching visits, which might not even need the doc time. But no, I think you'd get some pushback if you started charging 3 times a week for a medical visit. The patient still pays their copay and deductible too, so they might even push back.
Right.
So yeah, we do them once a week per doctor. The other doctors may do them other times, and usually people take a break. So most commonly, if they're coming back for a group visit, it's at least 2 to 6 weeks later.
Mm-hmm. It may work better. I mean, in another model would be when we move into the value-based,
Value-based, yep.
right?
Yeah.
Which of course is this, the dream that's right out there. Keeps
Yeah.
getting a little
Yeah.
farther and farther away. Who knows what's going to happen
Yeah.
now?
If you're taking full risk, you can do whatever you want.
But I'd like to thank our our presenter, Dr. Saul Bautista, who did a wonderful job tonight. We've actually got requests for you to come back and do another one. I think what we'll do is invite you to our Lifestyle as Medicine lecture series, so you can just give the whole presentation. I also like to thank Dr. Rebecca Monk, who is our guest panelist tonight, who's the Chief of Medicine at Highland Hospital in Rochester, New York. Thank you so much for your wisdom. And of course, thank you to Melissa Sunderman. Dr. Sunderman is one of our regular panelists, along with Dr. Robert Brakey from Michigan, and Dr. Carrie Graff, our medical director. Thank you very much.